Hi, welcome to Strategies for Safe Opioid Discontinuation. My name's Julie Kirk. I'm a pharmacist and professor in the Department of Family and Community Medicine at Wake Forest School of Medicine. My colleague, Courtney Perry, and I have developed a slide deck that we hope will aid you in thinking about discontinuation options for patients on chronic opioid therapy. The objectives of today's presentation include a discussion of approaches for slow titration in patients who are on opioids, and to define what entails opioid use disorder, review medications involved in opioid use disorder, and then looking at some of the strategies for opioid discontinuation. And then finally to describe medication-assisted therapy options with drugs like Methadone and Suboxone. Opioid misuse has become epidemic. In 2016, 11.5 million people misused prescription opioids, and 2.1 million had opioid use disorder, with more than 42,000 deaths due to overdosing opioids. You can see from the multitude of numbers here and the economic impact that this is an issue that we must deal with. Opioid use disorder is an increasing problem. From 2004 to 2008, the ED visits related to non-medical prescription opioid use more than doubled, not to mention the economic cost of over $500 billion, and the recent spike in unintentional deaths quadrupled since 1999. Let's talk about opioid mechanism. Opioids can be classified according to their effect at the opioid receptors. In this manner, opioids can be considered as agonists, partial agonists, and antagonists. Agonists interact with the receptor to produce a maximal response from the receptor. The analgesias following morphine administration is an example. You can see full agonists include heroin, oxycodone, methadone, hydrocodone. So, antagonists are the converse. They bind to the receptor but produce no functional response, at the binding of that receptor. Naloxone is an example of that. Partial agonists bind to receptors but elicit only a partial functional response, no matter the amount of drug administered. An example of this is buprenorphine or Suboxone that we'll talk a little bit more about later. There are a multitude of endogenous opioids throughout the body. They attach to teeny parts on the nerve cells, opioid receptors, and the receptors are in the brain, spinal cord, and digestive tract. Opioids have effects on breathing. They can stop coughing. They reduce feelings of pain in the spinal cord. And the opioid peptides and receptors are distributed along the GI tract and may modulate motor and secretory functions. There are three well-known opioid receptors in the body: the mu, delta, and kappa. And I've organized additional information about these receptors at the top of the slide. The mu receptor is the main opioid receptor in the body, which can be broken down into two subtypes. The mu1 receptor is associated with analgesia properties, while the mu2 receptor is associated with respiratory depression and constipation. So let's use an example. Morphine binds strongly to the mu receptor, and it produces a variety of effects such as euphoria, nausea, itching, and constricted pupils. Of all of these side effects, respiratory depression is the most concerning and can be fatal in an overdose. So when we look at opioid receptor pharmacology, again, we're going back to full agonists, partial agonists, and antagonists. When an opioid binds to the opioid receptor, they bind as full agonists, causing the sensations of euphoria and pain relief. Buprenorphine binds as a partial agonist, to the opioid receptor, which prevents the opioid medication from binding while still providing some pain relief for the patient. Because buprenorphine is a partial agonist, the patient will not experience rapid withdrawal symptoms and can comfortably taper off of their opioid medication. Another medicine to consider is naloxone, which is a pure antagonist at the opioid receptor. Because naloxone is an antagonist at these receptors, it prevents the opioid medication from binding but does not provide pain relief. Naloxone is often combined with buprenorphine so the patient will have some pain relief while tapering off of their opioid medication, and that is the Suboxone alternative that will continue. So let's review the effects of opioid receptor pharmacology. Heroin will have a full agonist effect at the receptor. Buprenorphine will have a partial agonist effect, and naloxone is a full antagonist at the receptor. Opioid use disorder is the misuse of medication that can lead to dependence in some patients who are at particular risk. The higher risk patients may be predisposed to dependence through genetics, medical conditions such as mental health disorders, prior substance abuse, or low pain tolerance. It is really important to closely monitor patients and look for some of the red flag warning signs to see if they develop drug-seeking behavior. For some patients, they can use medications appropriately and still be dependent. And that is probably the most difficult situation because as we talk about discontinuation, the struggle is those patients who use medications appropriately want to come off of opioids and then eventually can develop opioid use disorder. So the lines are a little blurred, but I'll try to make a distinction because as we look at addiction, opioid use disorder is the use of medication outside the normally accepted standard for that drug. There's cravings and preoccupation with the use of the opioid or drug at hand, loss of control, and requesting early refills, demanding higher doses, doctor shopping, and inconsistent results on urine drug screens are warning signs that patients have an opioid use disorder syndrome. So when we look at the large cartoon here as he develops opioid use develop, or she, we have misuse or overuse, diversion, drug-seeking behavior, scamming, and chemical coping issues. Once a moderate to severe opioid use disorder has been diagnosed, there's strong evidence for efficacy of using medication-assisted therapy with methadone or buprenorphine maintenance combined with behavioral therapies compared to non-medical treatment. Maintenance treatment leads to lower rates of illicit opioid use, reduces healthcare utilization and criminal justice involvement, and we need to be thinking about non-pharmacologic treatments. We'll talk about slow discontinuation of meds in some patients where that can be successful, Narcotics Anonymous, psychotherapy, family counseling, and of course the pharmacologic treatments that we've been mentioning along the way, including methadone and buprenorphine. In this slide, you can see how to convert commonly prescribed opioids into morphine equivalents. Not all medications have the same IV to oral ratio, and it's important to keep in mind that the relative potencies when choosing a medication regimen for patients can vary. For example, hydromorphone is 5 times more potent when given intravenously compared to the oral formulations. Absolutely needed. They're mandated in the state of North Carolina now to prescribe the lowest effective dose, carefully reassessing evidence of individual benefits and risk when considering increasing dosages where morphine milliequivalents are above 50 per day, and to really try to avoid increasing dosages or using anything above 90 morphine milliequivalents per day. To evaluate the dose of an opioid, by doing the calculations to evaluate morphine milliequivalents, we can keep prescribing to a limited amount, and usually no more, and it's limited by the North Carolina Stop Act, to no more than 3 to 7 days for therapy of acute pain. Long-term opioid use often begins with treatment of acute pain, so we discourage that and we try to use alternatives that are non-opioid. We try to prescribe the lowest effective dose of immediate release opioids and no greater quantity than needed. So if we calculate daily morphine milliequivalents, we add up the total daily dose of the current opioid prescription, we locate the ratio of the morphine milliequivalent for the current opioid, we multiply it, and we get an amount for each opioid medication in case patients are on multiple pain-relieving opioids, which can happen, and we try to keep the minimal amount for all opioids less than 50 if possible. In this table, you can see the conversion factor of commonly used opioids. Hydrocodones are 1-to-1, so we're able to add up the amount and we don't have to do any conversion. However, when we use, for example, oxycodone, we need to take the total amount and multiply that times 1.5 to get the morphine milliequivalents. Some examples of common amounts prescribed for a 50 morphine milliequivalent a day would be hydrocodone, 10 tablets, and that often comes as a combination of hydrocodone with acetaminophen 5/325. You've got the 5 milligrams, you multiply that times 10 tablets, and that's where you get your 50 morphine milliequivalents. If we used oxycodone, that would be about 2 tablets, and then the methadone, 12 milligrams, we can see less than 3 tablets. On the other hand, on the right-hand side of the slide, you see the number of tablets that would be equivalent to 90 morphine milliequivalents per day. That would be about 9 tablets of the hydrocodone acetaminophen 10/325. 10 milligrams of hydrocodone with 325 milligrams of acetaminophen. Opioid-induced hyperanalgesia is a condition characterized by a paradoxical response whereby a patient receiving an opioid for the treatment of pain actually become more sensitive to certain painful stimuli. One option is to taper the dose, and in many situations, the pain will improve. During tapering, it's very important to inform patients that opioid withdrawal is associated with physical pain and does not necessarily represent progression of their underlying pain syndrome or disease. It's important not to reassess any type of patient pain until acute opioid withdrawal is complete, and that can vary anywhere from 2 to 4 weeks or longer. Now, many patients fear that their pain will increase during opioid tapering, but evidence and studies of long-term opioid treatment tapers report actual improvement in functioning without associated worsening of pain. Withdrawal is inevitable when a patient is recovering from opioid addiction. Some patients can experience withdrawal symptoms as early as 6 hours after the last dose of their medication, while others may experience withdrawal symptoms a few days after the last dose. Counseling patients on withdrawal is very important, as they need to be in touch with what is going to happen and not be fearful of the process. Symptoms can vary, and I've listed out the variety in the time course, including anxiety, abdominal cramps, vomiting, myalgias, fatigue, tension, restlessness. Let's talk a little bit now about discontinuation strategies. When discontinuation is considered, it is very important that patients are on board with what the options are. Most commonly, tapering will involve dose reduction at a very slow rate. It can be anywhere from 5 to 10% every 4 weeks. More rapid tapers may be required in certain instances, such as drug diversion, illegal activities, or situations where the risk of continuing the opioid outweigh the risk. But in general, for successful slow discontinuation in patients that do not want to do medication-assisted therapy with methadone or Suboxone, a slow discontinuation can be an option. You will get to know the patient very well, and they will need to come in for multiple visits and be totally on board with a very slow process. It is not unreasonable to take many months to wean somebody off of chronic opioid therapy. The other thing to consider is to provide non-addictive medications to lessen symptoms of withdrawal. These can include anti-nausea regimens, antidiarrheal agents, muscle relaxants, and even drugs like clonidine can help with reducing sympathetic activity and reducing symptoms of withdrawal. Keep in mind, clonidine can be very sedating, so we try to use the lowest dose possible if we do consider that alternative. It is imperative that we avoid benzodiazepines because they can lead to cross-dependence in some people, and it's really advisable to avoid benzo use with opioids if at all possible in patients. Inform patients that every time they decrease the dose, they were likely going to have withdrawal symptoms, included the potential for withdrawal-mediated pain. In the absence of validated protocols, empirical plans have been proposed and often reduce the dose of medication to the smallest commonly available unit and then increase the amount of time between doses. If a patient's unable to taper off short-acting opioids, we switch to equal analgesic doses of longer-acting opioids. Again, the role of methadone or buprenorphine can be used in this process. We warn patients about what to expect during each dosage reduction, including a potential resurgence of pain, which they may mistakenly attribute to an exacerbation of the original injury or condition. Patients need intense psychosocial support when tapering off chronic opioid. All should get counseling. The success rate will be better in the situation for patients trying to slow taper, discontinue opioids, and assure them that the pain is withdrawal mediated, time limited, and usually not life-threatening. I'd like to talk a little bit now about opioid use in our youth. In 2015, over 4,000 youth aged 15 to 24 died from drug-related overdose. Over half of these were attributed solely to opioids. The numbers are getting better, though. Among high school seniors, past year misuse of pain medication, excluding heroin, decreased to 4.2% in 2017. Past year misuse of Vicodin decreased from a peak of 10.5% in 2003 to 2% in 2017. And OxyContin misuse has decreased from a peak rate of 5.5% in 2005 down to 2.7% in 2017. Students who are seniors believe that opioids are harder to obtain than in the past. In 2010, 54% of students who were seniors believed that these drugs were easily accessible as compared to 35.8 in 2007. Let's think about risk and protective factors that we can implement in youth. Youth at increased risk of opioid misuse include those with acute and chronic pain, physical health problems, or a history of mental illness such as depression or other substance use or misuse. Youth who've witnessed a family member overdose or who have a large number of friends who misuse prescription drugs also are at risk. And national data showed that nearly half of adolescents ages 12 to 17 who reported misusing pain relievers said they were given or bought them from a friend or relative. This number is over half for youth adults ages 8 to 25 who reported misusing pain relievers. One statistic reports that about 50% of adults with substance use disorder had opioid use before age of 18. Let's switch gears now and talk a little bit about discontinuation strategies in pediatric acute care. Most data regarding safe discontinuation of opioids in this setting relates to iatrogenic withdrawal in the acute care setting. Patients are scored after coming in, after being on continuous infusions of an opioid, and a decision is made to start intermittent enteral dosing of methadone or morphine. Most patients who require opioid infusions for 7 days or longer will require some type of pharmacologic plan for weaning. Multiple scoring tools exist and have been validated in the peds setting, and I've listed these tools out. The scores vary on components and required observation periods. No data suggest improved outcomes of one tool over another. However, improved outcomes with standardized protocols used in each hospital setting help with decreased rate of withdrawal, decreased exposure, cost, and shorter length of stays. For discontinuation strategies in peds acute care, most common agents utilized include enteral methadone or morphine. Weaning protocols vary by institution and typically range from 10 to 20% reduction in dose every 1 to 2 days, and the duration of the wean can vary. Discontinuation strategies in our pediatrics adolescent outpatient settings are lacking. Data regarding management of opioid use disorder is limited, with about 2.4% of adolescents in treatment for heroin addiction that receive pharmacologic treatment, compared to over 25% of adults. When we look at medication-assisted therapy, Bell et al. Found that methadone was more effective than buprenorphine at retention in a treatment program for adolescent heroin users, while Moore et al. Found that the buprenorphine naloxone combination was perceived to be more effective than methadone for reducing cravings and eliminating withdrawal symptoms, and to be less stigmatizing as a medication than methadone by adolescents. And that's probably by use of how they get the medicine from their providers. They don't have to go to a methadone clinic per se. So discontinuation strategies need to link patients with counseling and talk to patients using motivational interviewing whenever possible. Useful questions to promote opioid change talk include, from your perspective, what are the upsides and downsides to continuing taking opioids when you talk to the patient? Ask the patient, how's your life now compared with before you started taking opioids? Ask them, are there any benefits to not taking opioids anymore? Suppose you continue taking opioids for the next 5 years. What would that be like? What would your life look like? Tapering examples, if we use morphine sustained release 15 milligrams, might look something like a morning, afternoon, and evening schedule using days 1 to 10, a slow tapering of tablets over the course of the days, hours, and how that might look And this comes from a pain management opioid taper decision tool done in the VA Clinician's Guide. The dropout rates and discontinuation process need to be addressed. Patients will refuse to taper opioids, and they'll resume long-term opioid treatment with a new prescriber, or even display aggressive behavior. And this creates a concern for providers even approaching the conversation about having a patient slowly discontinue off of the chronic opioids. When specifically examining predictors for difficulties during tapering, depressive symptoms at initiation can be a significant factor for dropout and relapse. So my recommendation would be to move slowly with patients with depressive disorder. Those would not be the first people in your clinic. You would want to get some experience with slow discontinuation. Mandatory opioid weans during rehabilitation is also associated with a high dropout rate, especially with patients on high-dose opioids. An opiate maintenance option with Suboxone or Methadone may be the best option for many patients. Patients have to be willing to engage in care long-term for success. The Drug Addiction Treatment Act of 2000, Data 2000, which is H.R. 2634, permits providers to treat opioid use disorder with Schedule 3, 4, and 5 narcotic medications. Buprenorphine is FDA approved in 2002 as a Schedule 3 for treatment of opioid addiction. Providers must apply for waiver to prescribe the buprenorphine or any of the other prescription scheduled drugs for opioid use disorder. And in the first year under the waiver, they're limited up to 30 patients, and then after the first year, they can request approval for treatment up to 100 patients. So providers undergo medication-assisted therapy training. It's 8 hours for physicians, 24 hours for PAs and nurse practitioners, and then they get an X on their DEA number at the end of their DEA number so they can work with Suboxone clinics to help patients with opioid use disorder. The FDA has approved the buprenorphine in several different formulations that I've listed here: the buccal film, the sublingual film, and the sublingual tablet, in a variety of dosages. And depending on the area, this combination, buprenorphine and naloxone, is branded as Suboxone. That is a combination agonist-antagonist that is used for medication-assisted therapy to treat opioid use disorder. Just to recap, buprenorphine is a partial mu receptor antagonist at the kappa receptor, has a high affinity, slow dissociation from the mu receptor, and it displaces other opioid medications, producing a less severe withdrawal symptom composite for patients who are weaning off of opioids. It does have the potential for abuse and dependence, and its advantage is that it may prevent the need for inpatient detoxification in some patients who are engaged, motivated, and willing to go to an outpatient treatment program with close follow-up. As a partial agonist, it activates the opioid receptors in the brain, but to a much lesser degree than a full agonist, such as heroin. Also acting as an antagonist, meaning it blocks other opioids from having an effect, and it's own to suppress withdrawal symptoms and cravings. So buprenorphine induction occurs. There's an induction period, a stabilization period, and a maintenance period. Some people stay on the medicine for life. Maintenance needs to be at least 6 months to a year, and it just depends on the patient. Side effects can include headache, sleepiness, urinary retention, constipation, and we'll have to monitor liver functions. It is metabolized in the liver by the cytochrome P450-3A4, and it has a pregnancy category of C. Naloxone is combined in the Suboxone. As we stated earlier, it's a full opioid competitive antagonist. We use it for rescue and harm reduction. Its onset is about 2 to 5 minutes. Its duration is 30 minutes to 120 minutes. And there are several formulations, including nasal Narcan, and then there is injections. Consider prescribing naloxone as a preventative rescue medication for patients with opioid use disorder, especially if heroin use is suspected. And I would argue in primary care settings, when we know patients are abusing, we need to make sure a family member has access to Narcan. We counsel family members or other personal contacts in case of an opioid-related overdose. Methadone is also an option. It's been around for over 50 years, and it was the only thing we had to use for heroin and opioid addiction. It is a full mu receptor agonist. It has a high affinity for the mu receptors, but as the other medicines in the opioid class, it has the potential for abuse and dependence. Methadone has been the mainstay of therapy, and in order for clinics to dispense methadone, they must have registration through Substance Abuse and Mental Health Services. The onset of action is 30 minutes to an hour. It has a long duration and a long half-life in the body, and the formulations include oral, solution, injection, tablets, and again, the clinic must be registered with the DEA and certified by SAMHSA. Methadone is metabolized through the cytochrome P450 enzymes, and its use should be monitored for a multitude of drug-drug interactions. If patients are taking medications that are also metabolized by these common enzymes, then dose adjustments may need to be made. Patients should be counseled on the effects of nausea, vomiting, sedation, and constipation. And there needs to be close monitoring for respiratory depression, QTc prolongation. And pregnant women who require therapy may begin methadone treatment in the second trimester to reduce serious withdrawal symptoms in the infant at birth. Methadone comes in a variety of formulations. The starting dose recommended is usually around 20 to 30 milligrams per day, and it can be titrated up by 5 to 10 milligram increments. Higher doses may be used, has a very long half-life, and it usually has to be tapered over several months to years to prevent relapse. Some patients stay on it for many years, and patients who may benefit from methadone include those who want to be in a structured treatment environment and rehab centers, those who benefit from office visits for methadone maintenance and have transportation, and it can just vary which provider would want methadone over Suboxone. So let's compare withdrawal treatment and tapered doses of buprenorphine or methadone. When selecting a medication, it's important to consider the benefits and risks of each medication before starting therapy. Buprenorphine has many benefits such as high efficacy rates, many dosage forms, and you can use it in pregnancy. It also comes in a combination with naloxone, Suboxone. You can see there's a 5-day taper. Low doses are usually ineffective, and there can be precipitated withdrawal risk with buprenorphine. On the other hand, methadone, there's less precipitated withdrawal risk. You can use it in pregnancy. It's inexpensive. But on the counterpoint, you have to do a long taper. There's a risk of QTC prolongation and probably a higher risk of overall diversion. So when comparing pharmacologic treatment of opioid use disorder, methadone and buprenorphine are equally recommended. For some, there might be a preference for methadone treatment if retention and a more structured treatment setting is needed, or if higher doses of medicine is needed, you can use higher doses of methadone that might be more effective in some individuals where chronic pain is not benefited by high-dose buprenorphine. On the other hand, buprenorphine is a better choice if there's concern over adverse effects, QT prolongation, overdose, and some primary care offices offer Suboxone medication-assisted treatment that takes away the stigma of going to a methadone clinic for some patients. So overall, the considerations we need to think about is that patients taking opioids as rescue doses less than once daily do not need a formal taper. Ultimately, finding a plan that an individual patient can embrace with a significant degree of personal engagement might be more important than following any specific protocol. Slow tapering can be successful in the patient who's motivated and is not dealing with mental health illnesses, depression, or other issues that make you think this is probably not the best time to try to wean my patient off of opioids with a slow discontinuation. Go back, reapproach it, don't forget about it. Medication-assisted treatment, or MAT, is an option that should be fully explained to patients, demystifying the stigma of taking Suboxone or Methadone. Outlined are the references, and I appreciate your time in listening to discontinuation issues around opioid use and opioid use disorder. Thank you very much.